Thank you very much, Ceann Comhairle. And first of all, I want to welcome the fact that we are having this debate, and thank you for providing with me some time to contribute to it, both as a member of this House and former Health Minister and former Head of Government. I think when we talk about universal health care or universal health coverage, one of the most important things we need to ask ourselves is how do we define it? Because it means, of course, very different things to very different people. But perhaps the best definition is the one offered by the World Health Organization, and that is that universal health care is very simply all people having access to a full range of quality health services when they need them without financial hardship. And that's all forms of health care: health promotion, prevention, treatment, rehabilitation and palliative care in Ireland. And I do believe it is achievable. Some people talk about universal health care in the context of having an Irish NHS, or copying the form of healthcare that they have in Northern Ireland and Great Britain. And I don't think that's a good model for the 21st century. Whatever about 1948, certainly not for 2024. And we see in the NHS, north of the border and across the border, a system in which patients wait longer, patients have poorer outcomes, and staff are paid less, and social care and health care are not integrated. And that's not a model that I think we should follow in this state. We see much better models on mainland Europe, for example, in Belgium, in Spain, and in Germany, where there's very strong community health services, but it's not necessarily free at the point of use. There may be co-payments, there may be refunds, there may be systems whereby everyone has insurance or is required to have some form of insurance. And of course, it's not necessarily state-run. We see in Germany, for example, hospitals run by voluntary bodies, by state entities, and also by private entities, therefore providing the maximum capacity and also competition and good value. The Sonjacare report, which I think encapsulates Ireland's shared ambition for universal health care, is a very good report. It is, of course, the one that has its limitations. It leaves many policy questions unanswered, and favours affordability over capacity, which I think is flawed, promotes making everything free or almost free ahead of actually creating the capacity to cope with that increased demand. And I think that's one of the flaws that hasn't been identified sufficiently. But it does speak to four things, all of which I strongly support. That is making healthcare more affordable, more accessible, with better patient outcomes, and to making sure that it's integrated and reformed. And I really want to take this opportunity to compliment Minister Donnelly on his team on what is very significant progress in the past 4 years, probably more progress that we've seen than in decades. Of course, he's had the money. He's been able to build on progress made by previous governments. But I do hope that Minister Donnelly and his team get credit for what has been achieved in the past 4 years, because it is considerable. And particularly want to congratulate Minister Burke now on being part of that team, having previously been Fine Gael Health spokesperson. So if you take the first of those four things, affordability, we see now that we free GP care for everyone under 8 and over 70, also for those in receipt of carers allowance. And now the means test is being relaxed to the extent to which middle-income families, working families, can now qualify for free GP care. Roughly 50%, if not more, of the population now qualifies for free GP care for the first time, even though huge numbers of people entitled to it haven't actually claimed it yet. And I think there's an issue there that we need to deal with. We've seen inpatient hospital charges abolished, medicine costs reduced through the DPS, no household paying more than €80 a month for their medicines, real improvements around sexual health, particularly around the PrEP programme and the availability of free sexual health testing through the post, IVF now being funded, contraception being funded for a lot of women, although not all yet, and of course the vaccine programme too. But I would encourage the Minister and the Government not to forget affordability. We're not there yet, and healthcare is still very expensive for a lot of people. Medication costs at €80 per month per household can still be quite high for a lot of people, and I think that should be brought down further, or perhaps like Finland have an annual maximum that nobody has to pay above for their medicines. There's also the difference between a medical card and a GP visit card. The department argues that the cost of upgrading a medical card or upgrading a GP visit card to a medical card is hundreds of euros. I'm actually sceptical about that, given that hospital charges have been abolished and drug costs have been capped. And we have seen over the past couple of years the number of full medical cards go down and the number of GP visit cards go up dramatically. And I think the next step should be to convert more medical cards, or more GP cards, into full medical cards. And I don't believe the costings, quite frankly, from the department on that. I don't think they're as large as is said. And then also to transition, on the second point which I mentioned is access. The case made for increased bed capacity by other members is well made. I don't need to repeat that. We also need to improve access to medicines. I still don't understand why there are so many medicines that are reimbursed in the UK, in Germany, in France and other places long before they are here. And I say that as somebody who tried to resolve that problem as Taoiseach as Minister for Health, as somebody whose Chief of Staff knew the pharmaceutical industry very well, having worked there previously, and it was a nut that we couldn't crack. And it's still not explicable to me as a doctor or as a politician to explain to anyone why a medicine that has been reimbursed some time ago in a relatively parsimonious health service like that across the water in England isn't reimbursed here yet, and there's a significant problem there. Good to see better access to diagnostics for GPs. I think that's really good. Good to see waiting lists having fallen for the past 2 years now in a row, bucking the international trend. I hope that happens this year as well. But we see huge variability, particularly between hospitals. And we know from bitter experience that emergency department overcrowding is only resolved when three things are right: capacity, clinical leadership, and strong management. And if one of those is missing, you have an overcrowding problem. And if 2 or 3 are missing, you have a very severe overcrowding problem. Good to see the progress we're making in terms of patient outcomes. You're 20 to 40% more likely to survive a stroke than you were in 2011. 20 to 40% more likely to survive a heart attack than you were in 2011. People live longer than ever before in Ireland. Life expectancy now in the top 5 in Europe. And most people survive cancer rather than die of it. Those things were not the case as recently as 2011. And I think we shouldn't forget that very real progress that has been made. Disappointed in some other areas, particularly around respiratory illnesses, COPD, that so much progress hasn't been made. In terms of integration and reform, great to see the Sauncha Care consultant contract up and running, and that doctors are signing up for it in good numbers. And good to see that the regional health organisations have been established. I'm not sure whether it's right, though, to put Children's Health Ireland under a particular region. I think that should be a national entity, and it should be seen that way. And it is regrettable that they're not legal entities. They don't have their own boards. They don't have their own bank accounts. One of the reasons why I think schools are generally well run in Ireland is the fact that they have a principal, they have a board, they have a legal authority, they have their own bank accounts. You could be a very large hospital in Ireland and not be able to procure something very simple, like a new set of bins for the offices, without having to go to the HSE. And I think there's a lack of autonomy there at local level and at RHA level. And of course, one of the real difficulties we have is when it comes to IT, which unfortunately is very bad in Ireland and requires a big investment. Because we know when new services are set up with new IT systems, they work very efficiently. That's not the case with the old systems. And we need to invest in AI as well, which is going to transform healthcare, particularly diagnostics. Finally, just a quick point I'd like to make about resources. Of course, it's important that we have a health service that is well-resourced, not just adequately resourced. But I do think we need to push back against people who always use resources as the excuse for problems in our health services. Politicians don't take it on enough. The media, when doing interviews, never question it or take it on. Those who always default say the reason why there's a failure or an inadequacy in our health service is because of lack of resources, lack of money, lack of staff. It's not that simple. And if you just take the big picture, if you take Ireland's health service now, is very well resourced. We're mid-table in terms of spending per capita. When it comes to nurses, we have among the highest number of nurses per bed and per head in the world, probably in the top 2 or top 5. We're now above average when it comes to the number of doctors per head, more than Australia now, for example. We're poor on bed capacity, though, and poor on infrastructure. So I do think in that context, the government is making the right decision by limiting the extent to which staffing levels can increase in our health service. They can add staff this year, but it's an extra 2,000 on top of the 8,000 last year. But it won't work if there isn't redeployment and if people's roles don't change. Because we have a lot of staff and they're working very hard and they're very busy, but we're not getting the outcomes from them that you get from the same numbers of staff in other health jurisdictions. And that is not their fault. It's a system that needs to be changed, and those who resist that change need to be stood up to. So you would take, for example, in other health services, work that is now commonly done by doctors and nurses in the Irish system would be done by a medical receptionist, or a health advisor, or a healthcare assistant, or a scrub tech, or a physician assistant. And those roles are not properly developed in Ireland. And we're not getting the best out of our highly qualified people. And that's a real part of the problem too. Also need particular focus, I think, on more senior staff and more specialist areas. Where public health nurses are appointed, where we have advanced nurse practitioners, where we have consultant-led services, we see dramatically better services than those that operate on the traditional model with one consultant with a very large team of junior doctors backed up by non-specialist nurses. And I think we can see examples around the country as to where best practice works but isn't being mainstreamed enough. But I do accept, of course, that the government and the minister have an extremely difficult job. If there's one thing that I've learned about politics, it's that describing and identifying a problem is very easy. Coming up with a solution is not always that difficult, but actually operationalising it is the real difficulty, because that can't be done by one person or one department or one agency. It has to be done by 100,000 people working together from the top to the bottom. And that's what, unfortunately, sometimes is lacking. But thank you very much for the opportunity to make the contribution.